Testing. Hello, can you hear me?
Yeah.
Great. Well, let's get started. My name is Dr. Bahrom Firozgary. I'm a primary care sports medicine fellow at the University of Texas Health Houston program. I'm presenting here at the Memorial Family Medicine Residency Program in Sugar Land, Houston, Texas. And today I'll be presenting a journal club article. The article that I chose is titled Platelet-Rich Plasma versus Hyaluronic Acid for Knee Osteoarthritis, a systematic review and meta-analysis of randomized controlled trials. I have no financial affiliations to disclose. As a brief overview, I'm going to go over the background of the article, the purpose, its study design and methods, and then I'll dive into the results, discussion, and conclusions from the article, and I'll leave time for some questions. So to start, an estimated 16.7% of people over the age of 45 years old have symptomatic knee osteoarthritis, and 27.8% show radiographic signs of cartilage degeneration. OA is one of the most common articular cartilage pathologies in the US, and it's a leading cause of chronic disability worldwide. Platelet-rich plasma, or PRP, and hyaluronic acid, or HA, these injections are supposed to symptomatically improve and delay surgical intervention in patients with knee osteoarthritis. HA is a naturally occurring glycosaminoglycan, and it's found in synovial fluid. And so it's been demonstrated that it's a safe and effective way to treat OA, in the knee particularly. And PRP involves using a patient's peripheral venous blood, and it's modulated to where you're injecting it back into an intra-articular environment to introduce the autologous blood products back into the joint. And that's been shown that it can reduce inflammatory distress, promote chondrogenesis. The purpose of this study, they mention it's to review the literature, to compare the safety and efficacy of PRP and HA injections for the treatment of knee OA. And the hypothesis mentioned in the article was that there would be no difference in clinical outcomes between patients receiving PRP and HA injections for the treatment of knee OA. The reasoning to that hypothesis, they mention, the increased mechanical and viscoelastic properties in the synovial fluid, and therefore HA should be adequate. And so that's why they said that there should be no difference. Mentioning study design and methodology, this was a meta-analysis of level 1 studies. Level 1 studies are defined as high-quality randomized controlled trials that are high-quality prospective cohort studies with adequate power. When choosing articles to review, there were 2 independent reviewers, and then a third if there were any disagreements amongst the first 2 reviewers, and that third reviewer made the final decisions. They utilized PubMed, Embase, and the Cochrane Library, searching the terms platelet-rich plasma, hyaluronic acid, knee osteoarthritis, randomized. So for inclusion and exclusion criteria, they utilized the PICOS strategy. As a refresher, PICOS, it stands for Participants, Intervention, Comparator, Outcomes, and Study Design. So for inclusion criteria, participants were patients with knee osteoarthritis confirmed radiographically. The intervention being performed or tested was intra-articular injection of PRP. The comparator was intra-articular injection of HA. And the outcomes assessed were clinical efficacy and adverse events. Study design, it's again, level 1 randomized controlled trials, and these were published in England. So of 210 studies, they narrowed it down to 18 that met the inclusion criteria. The exclusion criteria was just simply level 2 to 5 studies that did not meet the aforementioned inclusion criteria. Here's an outline of the PRISMA model. It's basically a flow diagram showing how they narrowed down from 210 to their 18 studies. So now for methods, the outcome measures, the studies involve different patient-reported outcomes These are different assessments of pain. So for 11 studies, they used the VAS, Visual Analog Scale. 12 studies used the WOMAC score, which is the Western Ontario and McMaster University's Osteoarthritis Index. And 7 studies used the Subjective International Knee Documentation Committee score, or the IKDC score. The risk of bias was assessed via the Cochrane Collaboration's risk of bias tool. And so I'll go to the next page where we can see a visual representation of what these would look like for the patient's reporting. So on the right is the WOMAC, on the bottom is the VAS, and on the left is subjective IKDC. And for reference, when you're reading the article, they'll mention different scores, and these were all scaled to a 100-point scale, with the WOMAC and VAS reporting systems having a lower score equals less pain. On the subjective IKDC, a higher score means less pain or an improvement of symptoms. So just keep that in mind as we get later to results. The VAS, as you can see, is on a 10-point scale. So again, the study just modified it. The meta-analysis made it a 100-point scale as well. For statistical analysis, a modified Coleman methodology score evaluated the methodology quality. Age and follow-up was just use a weighted average. Forest plot, if there were 3 or more studies available, that was utilized. I2 statistics calculated the degree of heterogeneity, and then a random effects model was used for the comparison of LP PRP, leukocyte-poor PRP, and leukocyte-rich PRP. Baseline characteristics. So amongst the 18 studies that met inclusion and exclusion criteria, there were 1,606 patients that were studied. 811 of those received PRP injections. HA patients were 797 of them. The mean age was 57.6 years old for PRP group and 59.3 years old for the HA group. The mean follow-up time was 11.1 months for both groups, and 49% of the PRP population were males, 40.6% were males in the HA group. In the study, PRP was prepared via a peripheral venous blood sample. It was then centrifuged to isolate the red blood cells from the plasma. In 13 of 18 of these studies, the erythrocyte layer, the bottom layer that we typically see, was then centrifuged again to isolate the platelet-poor plasma from PRP. Leukocyte-poor PRP was utilized in 8 studies, and leukocyte-rich was utilized in 7 studies. 3 of the other 18 did not disclose what type was used. For the hyaluronic acid preparation, 13 studies used high molecular weight HA preparation, 3 used low molecular weight preparation, and 2 did not specify the molecular weight. The approaches for both groups, again, they were compared. Ultrasound-guided supralateral was used in 9 studies, ultrasound-guided anteromedial 2 studies, supraramedial 1 study, and 6 studies did not disclose their approach. Here's a breakdown of the many different injections to intervals used. So for 8 of the studies, you can see there's 3 injections at 1-week intervals, for 4, 3 at 2. For the sake of time, you can read the rest, but just as a summary, you can note that there's quite a few different injection numbers and intervals. So a decent variety, actually, throughout the meta-analysis. Here, going into results, for the studies that utilize the WOMAC total score, so again, a lower score indicated less pain. This table says a lot. I highlighted in red the important lump sum results that they mentioned. So at a minimum of 12-month follow-up, so meaning at 12 months or more, when the patient was last seen and assessed for pain, they saw a decrease in about 13.6% pain for those receiving PRP versus HA. So that means the group receiving PRP reported a 13.6% better improvement in pain than those receiving HA. And so for those seen in under less 12 months, less than 12 months, so under a year follow-up, they reported an 18.4% improvement in pain, greater than the HA group. To note, though, if you look at more closely in the article as well, the HA group did mention improvement in pain. The PRP was just greater in what they reported. Same went for the VAS scores in pain severity. So again, in the group at over 1 year follow-up or 12 months follow-up, they saw a decrease in about 9.9% of pain compared to the HA group, whereas those in less than 12 months saw an increase in 0.5% of their pain. To note, though, these were not found to be statistically significant. And in this group, as well as mentioned in the WOMAC score, HA patients also saw an improvement in pain. The PRP, not statistically significantly, saw a greater improvement in pain. Lastly, for figure 5, using the subjective IKDC score breakdown, they had only one group, essentially it was greater than 12 months follow-up, that was assessed, and that showed a improvement in pain. In the PRP versus HA group, it was about a 6.7% improvement in their pain. So with that being said, what does all that mean? We'll get to that in a few slides. First, there was also, as mentioned, a comparison of the leukocyte-poor and leukocyte-rich groups. They weren't compared directly, it was just compared leukocyte-poor to HA, and then those results in comparison to the leukocyte-rich versus HA. So at latest follow-up, 5 out of 8 outcome scores showed leukocyte-poor to show significant improvement in pain compared to HA, whereas the leukocyte-rich group showed 5 out of 10 outcome scores showing significant improvement compared to HA. And in none of the studies did HA have a greater improvement in pain than PRP. The leukocyte-poor group showed greater improvement versus HA than leukocyte-rich PRP in subjective IKD scores, with no difference in WOMAC or VAS scores. So that bottom line, sort of the lump sum summary that they made in their results section. Lastly, a final group that they had mentioned, or statistic they had looked at, was the osteoarthritis grade. So using the Kellgren-Lawrence scale, they mentioned which articles did define a post-injection osteoarthritis grade, and only 3 of the 18 did that. In 2 of those 3, those studies only had patients with grade 1 through 3 OA, and in one of those studies, there was found to be no significant difference pre-injection and post-injection last follow-up. And in the other study group of those 2 using grades 1 through 3, found that actually the groups with grade 1 OA showed a greater improvement in pain compared to the grade 3 group. And in the third study, they found that grade 1 through 3 osteoarthritis patients reported better pain reduction than patients receiving injections who had grade 4 osteoarthritis. And again, these are just in the studies looking at post-injection osteoarthritis grade on imaging. With all that being said, the last couple of slides, the summary of those results is that the mean improvement in PRP group was greater than the HA group using WOMAC scores, PRP being 44% improvement in pain, whereas the HA group showed a 12.6 improvement in pain. 6 of 11 studies reported PRP patients having less pain compared to the HA patients using VAS scores. 3 of 6 studies reported better scores in PRP patients compared with hyaluronic acid at the latest follow-up using the subjective IKDC outcome scores. They also inferred that leukocyte-poor with subjective IKDC scores showed better improvement in pain than leukocyte-rich recipient patients. So to discuss these results, the inference can be made that patients undergoing treatment for osteoarthritis with PRP can expect a greater improvement in pain compared to those receiving HA. The results can be explained, in particular, and this has been studied more outside of this meta-analysis, but the biological components found in PRP that are being reintroduced into cartilage, those can be maybe as the article mentions too, the reason that we're seeing this improvement in pain. They mentioned growth factor B, insulin-like growth factor, and VEGF, et cetera. Leukocyte-poor PRP may be superior for knee OA over LR PRP. However, the ideal PRP composition for treatment of knee OA remains controversial. The article mentions it, and as our field might know, that's a pretty accurate statement. So the limits of the study, the results were great in theory, but there were so many various injection numbers, schedules, intervals, even the components and the products themselves differed, the approaches differed. So just that variety, it's hard to have a head-to-head one-liner statement for PRP versus HA from the meta-analysis, what it was looking at. Performance and detection bias in this study were high. It was mentioned in the colored, I'll just show quickly, in the graphs next to the results. So the red showed high variety or risk of bias. So basically in roughly 30% of cases that was seen. So again, that could have played a role in the results. As mentioned, administration schedule had varied. There were potential conflicts of interest disclosed for the multiple authors on the second page or first page. It's almost half the page. You can see that they're relying and potentially funded by some companies that would promote PRP over HA. And lastly, patient costs. In the real world, at least anecdotally in the clinics that I've been in, I haven't seen much of a 1 PRP shot every 3 weeks or 4 PRP shots every week for 4 times. I think that's an ideal situation, and if there's funding to permit that for patients, however, from what I've seen, it's usually self-pay and pretty costly for patients. So in the studies, essentially, the costs of the patients weren't really looked at. I think from what I was reading, it was basically gratuitous injections since they were enrolled in the study. Further considerations that we can use to look at maybe the rate of progression from injection or no injection PRP and no or hyaluronic acid to knee arthroplasty. So whether they get it or not, and then how long that takes, that would be a good comparison. Post-injection management, what were they being told to do? Some people say rest for X amount of time. If that differed, it would be good to see maybe what the improvement is with different PT, as the third bullet mentions, schedules. So just looking at the variety of post-injection instructions could be of benefit. And lastly, just a direct comparison between leukocyte poor and rich, that as we read further, we're seeing maybe some of these differences are a little bit more clear, but also more cloudy. And as mentioned by the article, comparing Kellgren-Lawrence groups and the grade of OA would be potentially a benefit to see what help it does have, PRP and HA. So with that, I have a little bit of time, but thank you all for listening. Any questions? I have a question over there.
Would this change your clinical practice?
So for those who couldn't hear, we had a participant ask, would this change my clinical practice? And I would say yes, but I would also say that I'm currently leaning towards PRP. I have, outside of this article, found that it's a benefit. It reduces pain. I think, yes, hyaluronic acid has been used as well, but this study is basically saying, hey, PRP shows benefit. Let's use that. And any other questions? Okay. Well, thank you. I'm going to hand it over to my co-fellow, Sammy Raad.
All right. Can you guys hear me all right?
Yep.
Okay. All right, so I'm Sammy Raad. I'm one of the other fellows here over at University of Texas, Houston. And the article that I chose for today's journal club is L-Citrulline improves splanchnic perfusion and reduces gut injury during exercise, a randomized double-blind crossover study. This is actually an interesting article since we were looking at supplementation in athletes over a recent didactic session. So I thought this was an interesting one to go through. Some learning objectives. So we're going to explain splanchnic hypoperfusion physiology and gut injury in athletes, distinguish the difference in metabolism between L-citrulline and L-arginine, and then we'll also discuss the limitations of this particular study. So some background. So strenuous physical exercise often causes these GI symptoms in these athletes, from mild nausea to even hemorrhagic stools. And the incidence of these symptoms vary between 25 to 70%, and that really depends on the intensity and duration of exercise. One proposed mechanism is actually a decrease in splanchnic perfusion. And this is due to blood being redistributed away from the splanchnic area towards active muscles, the cardiopulmonary system, and the skin. And this has been actually postulated as the key mechanism behind these exercise-related GI symptoms. This can lead to abdominal distress, impaired nutrient absorption, and even reduced athletic performance. Increasing nitric oxide availability is a potential strategy to enhance intestinal microcirculation during exercise-induced splanchnic compromise. And nitric oxide is produced by activation of endothelial cells as well as inducible nitric oxide synthase. While nitric oxide only has really been used for more pulmonary issues like pulmonary arterial hypertension, can't really be applied locally to other organs. So L-arginine was then being used as a nitric oxide donor and has been studied, but results were not conclusive, and it actually caused more side effects, even some GI side effects. This is where L-citrulline came into play. It's a non-protein amino acid. It's a precursor of arginine, and it actually enhances L-arginine availability for nitric oxide production. 10 grams of oral L-citrulline supplementation has been shown to improve muscle protein synthesis without these side effects. So this study actually was done to test whether oral supplementation of L-citrulline before exercise improves splanchnic hyperperfusion, and if it can reduce exercise-induced GI injury. So here's a little picture here that I actually found on a different article that talks about the production of citrulline and arginine. So we have to kind of put our biochem hats back on a little bit here to see this. So citrulline, and as you first can see, there's a lot of watermelon at the top here, and that's actually not by mistake. Watermelon actually contains quite a bit of citrulline in it. And this study found that 5 kilograms of fresh watermelon can produce up to 10 grams of L-citrulline, which that's about 10 pounds of watermelon. And I got to say, I like watermelon, but I don't know if I like watermelon that much. So citrulline can be put into the system, into the portal vein, and goes through the liver. And in the liver, it actually has almost a 1-to-1 ratio where it goes back out into the system, while arginine will go into the enterocytes and create ornithine as well and go into the system, then being produced into the liver again, or being pushed into the liver again. And that's where it actually does a lot of its process to create urea. So it actually gets metabolized in the liver, while citrulline continues to go through. It doesn't get metabolized in the liver and gets metabolized in the kidneys, thus creating arginine there. And being produced into the system again. And that's this little area here, you can barely see it. That's where arginine is being created into nitric oxide for both skeletal muscle over here, as well as into vascular smooth muscle cells. So the citrulline has its own little route that it goes through and being broken down by the kidneys instead of a liver. And that's kind of the big component here. For methods, this study particularly took 10 healthy active men, age range of 24.9 plus or minus 1 year of age. Their BMI was around 21.1 plus or minus 0.4 BMI. And all these selected volunteers spent 3 to 15 hours a week for endurance, had their own endurance sports as their normal lifestyle. The maximal workload capacity was tested in these athletes using a stationary cycle ergometer, which is basically a fancy bicycle that measures energy expenditure. So the volunteers had no abdominal complaints at all before the study. They didn't have any history of smoking, no medications for the last month before participation, no history of GI disease, no history of abdominal surgery. Participants maintained normal activities of daily living, but refrained from any strenuous physical activity for 2 days before each test. And then ranitidine was also given to each patient on each day of the test, and then again the evening before each test, and then the day of the test, 60 minutes before testing. So they really wanted to make sure these athletes had no GI symptoms whatsoever before testing. So the study design, this was a randomized, double-blind, placebo-controlled crossover study. The participants were randomized in 2 different interventions. One was an oral citrulline supplementation group. They were given 10-gram bolus of L-Citrulline in tap water. Then the placebo group had 20 grams of L-alanine in tap water. All subjects performed 2 test days in an order that was randomly assigned to them by a computer. Excuse me, the test drinks were identical in appearance and smell. No additives or sweeteners were used to keep drinks highly pure, and the time between test days were at least 7 days. So the way sampling was done was that they took arterial blood, they sampled arterial blood for PCO2 at 10-minute intervals before, during, and after cycling. They also tested gastric PCO2, measuring this at the same intervals as when they test for arterial blood. They used an automated capnograph via the nose into the stomach, and that was actually fixed to the nose of these patients while they were cycling. Baseline side stream dark field sublingual imaging was also performed during this time. This was to test to see perfusion of the citrulline as well as the alanine. And this was an image put under, this was an image that was taken underneath in the sublingual area. After baseline measurements, participants would drink the bottle that they were assigned. 30 minutes later, participants then started exercising. And then immediately after 60 minutes, of exercising, additional side stream dark field sublingual imaging was assessed. At any point in time, GI complaints of the subjects during the testing were registered, and then subjects were then contacted 2 days later to assess for GI complaints on the day after each test. After they collected all this data, they gave us some nice graphs in here. And the way to look at it is looking at the top right there, there's the placebo in the white, and then there's the citrulline on the left, or on the black. And this is on the y-axis is the plasma citrulline versus time. So the citrulline obviously went up during exercise and then slowly back down with patients that took citrulline during the exercise, while placebo was alanine, and that was 0 plasma citrulline. For plasma alanine, the placebo would go up and then slowly go back down, while with citrulline, the plasma alanine would not really move much. The interesting thing that we saw, I guess not so much interesting, but we know now from biochem, is that with citrulline, the arginine would go up. And the interesting part of this is that it would stay up even post-exercise for the citrulline patients. For the placebo patients, that would stay pretty normal and low. The arginine availability, however, that is arginine divided by ornithine plus lysine. And if we go back to our little diagram up here, that would be the total arginine basically in the circulation, theoretical arginine circulation. So that'd be arginine, the total arginine, over ornithine plus lysine. And that would give you the arginine index, arginine availability index. And that would also be up and stay up throughout the exercise and post-exercise. The next graph was the gap PCO2, and that was assessing the arterial PCO2 versus the GI PCO2. And the way that to interpret this graph is that, again, this is the placebo here, and this is citrulline. And with the increase in the number here, it's actually going to be a decrease in perfusion. So basically, the perfusion was increased initially with citrulline, and then post-exercise, it would start to decrease again, while for the placebo group, it just stayed basically decreased throughout the whole experiment. The perfusion there. And then another way to assess for perfusion again would be through the sublingual imaging that they did. And they assessed the microcirculatory vessels to see the perfusion that was present there. This graph up here was just looking at the microcirculatory vessels in the sublingual area. This was looking at the microcirculatory vessels plus also the larger vessels that were greater than 10 micrometers in size. So with the citrulline group, the microcirculatory vessels had increased in their perfusion up here, post-exercise and post-exercise, while the placebo did not. The placebo group the citrulline group on this side for the total vessels, large and microcirculatory, would also increase the perfusion there with the citrulline group. And then with the placebo group, it did not. So in conclusion for the study, oral L-citrulline supplementation before exercise enhanced the AAI during exercise compared with placebo. Oral citrulline supplementation before exercise maintained adequate splanchnic perfusion. And then citrulline reduces exercise-induced small intestinal injury during exercise. So this actually, those three graphs are showing. So this is showing great numbers in these patients. But I wanted to take a minute and talk about some limitations of this study. So first off, it was a small sample size. The study was conducted on a small sample size of only 10 healthy males. This limits generalizability of the results to a larger population. And then there's the lack of diversity in the sample. The study only really included healthy males. This limits generalizability to females, elderly individuals, and even individuals with medical conditions. And then they also had this correlation equals causation model here where they were testing the sublingual microcirculation equals perfusion of the Splanchnic microcirculation, which the bullet point down here shows that there's an NIH article that came out that actually showed that changes in sublingual microcirculation doesn't necessarily parallel. This data may not always represent intestinal microcirculation. And then lastly, it was a short duration study. Participants were only given 2 days to do this study in a span of a week, and they flip-flopped each week. So the limitations for long-term effects of L-citrulline supplementation on the gut injury during exercise is limited here as well. So some final thoughts. This study found that L-citrulline supplementation improved splanchnic perfusion and prevented splanchnic hypoperfusion during exercise compared to placebo, and it may help reduce intestinal injury and improve athletic performance. The increase of arginine availability resulting from L-citrulline intake actually helped contribute these effects. The study also found that L-citrulline intake resulted in increased number of perfused small sublingual vessels and attenuated plasma during exercise compared to placebo. The results suggested that L-citrulline supplementation is promising intervention for combating splanchnic hypoperfusion-induced intestinal compromise. Overall, I believe that while this study does provide valuable insights into potential benefits of L-citrulline supplementation on gut injury during exercise, its limitations should be taken into consideration when interpreting the results. And further studies with larger, more diverse samples and longer durations are needed to confirm and expand upon these findings. Thank you. These are my citations there. Any questions? Yes.
So as a female, would you recommend that I start citrulline? If I was one of your patients that's pretty active, what would you say?
I would say give it a shot. This is something that, yes, while females weren't done in this study, we do see what it can happen in the human body in general. So this would be something that we would see happen, and it doesn't really give a lot of side effects. So I say go ahead and give it a shot and see what happens. The other thing is that we can say that it is somewhat safe because these were actually very large doses. These were done with 10-gram doses, while over-the-counter doses were around 1 gram when we're looking it up. So, thank you.